Welcome, welcome. We are now at the final block of sessions for Retreat Migraine 2020. We thank all of you for coming along with us on this journey. And I'm really excited about this topic we're going to be sharing with you to start this evening. So the topic for this session is strategies for avoiding the ER. And I'll jump to the end conclusion is, within reason, patients deserve access to the treatments they need to stay healthy, to manage their disease, and to stay out of the ER. And I think there's a lot of room for improvement here. And the way to get there is by patients who have been through this journey to share their experiences with others and sort of learn from that side, and then to have a really knowledgeable physician explain what some of these various strategies are, what some of the things are that people can talk to their doctors about, reasonably getting prescribed to them for at-home use, so that hopefully they can have better control of managing their disease and staying out of the ER. So first I want to welcome Tammy Rome. She is a licensed therapist specializing in headache disorders. She has leadership roles with migrainedisease.org and the Cluster Headache Support Group, both of which are CHAMP Coalition organizations. She now lives in Germany, where she is joining us from this evening, and she's helping patients there to live better lives with migraine and other chronic conditions. So welcome, Tammy.
Thank you, Kevin.
Got it. And let me introduce Bill next, and then I'll bring it back to you. So Dr. Bill Young is a neurologist and headache specialist at Thomas Jefferson University Hospital in Philadelphia, Pennsylvania. He does fantastic work bringing attention to migraine and the stigma against migraine. For example, this morning he got up super early to do a 40-minute interview all about migraine on Sirius XM Doctor Radio program. And now, after a full day of seeing patients, he's with us this evening so he can share more of his knowledge and help to patients. So that's just sort of par for the course for him, burning the midnight oil on both ends, the mornings through the evenings, in support of patients. So Bill, thank you and welcome.
Thank you.
We're going to start off with Tammy sharing her journey as a patient been living with migraine for quite some time and what that's been like and where she's at now. So Tammy, please take it away.
Thank you, Kevin. Good evening, everyone. Greetings from Germany. Just landed early this morning. Now I'm here, migraine-free, yay. I've been living with chronic migraine since I was 5 years old, and had my first visit to the emergency room when I was about 20. It fortunately was a good experience. We don't always get those. I've had my share of bad ones, but we all would prefer to avoid that emergency room entirely. And unfortunately, it's not always avoidable, but I did learn a few tricks along the way, not only with medication and medical treatments that Dr. Young will speak about, but some of the practical strategies for treating yourself at home, even with non-medical strategies, to help you cope with the migraine. And one of the things that took me a long time to figure out is how to use different comfort strategies in addition to my medical treatments that helped me to relax so that I didn't give way to the anxiety and the panic of anticipating the pain or anticipating the nausea. So I learned very early with the medications that I was provided also to use ice, heat, massage, different scents. Some people are sensitive to those, so you have to find the ones that work for you. But I found ways also to provide sort of a sensory deprivation environment where I had blackout curtains, a sleep mask, close the doors, use noise canceling headphones, and all of these different strategies to provide myself with a minimal amount of sensory input during the time when my brain just could not handle it. And that actually helps me to relax and to sleep, which we have all been told is one of the best ways to relieve migraines. If you can get to sleep, then you can often wake up without one. Obviously, that's not foolproof. And I used a lot of these strategies, and I learned by my 30s that if I could keep from panicking, I could actually control my pain levels to the point that I could relax and work my way through for that migraine to end with medication. And then into my 40s, I began to realize that each time I had to go to the emergency room, I was treated with exactly the same cocktail of medications. It worked for me every single time. Well, it wasn't too far into it, about 2013, when I discovered that those same medications were available by prescription for use at home. The trick was that I had to learn how to give myself injections or recruit one of my family members to give me the injections when needed, because usually by the time I needed one, I was in a lot of pain. So I tended to be shaky and nervous. And at first, I didn't feel safe and comfortable giving myself the injection. And in the beginning, it was my teenage son who would, he called it throwing darts at mom, who would give me my injections that I needed, that actually allowed me to get that backup treatment in when my triptans didn't work. It allowed me to get that treatment in very early so that as soon as I knew that the triptan wasn't working, I could immediately go to that backup rather than waiting 3 days to see if the migraine would go away before I gave up and went to the emergency room. And so I actually was able to stop that migraine in its process faster because I had the treatment at home and I could get it in faster and easier. I was very nervous about talking to my doctor about this because I didn't know how he would respond to me asking for a more invasive treatment. Fortunately, the doctor's only concern was my comfort level. Could I learn how to give myself an injection? It was nerve-wracking, and it took longer for me to feel comfortable giving it to myself than feeling comfortable letting my son or my husband do it. But we did get it done, and it did work. Since then, even my preventive is an injection, and so I've gotten very comfortable with those injections. And fortunately now, I hear a lot of people who are afraid of needles. Unfortunately, there are a lot of medications. If the pills don't work, there are nasal sprays, suppositories, there are neuromodulation devices. There are lots of ways to get a migraine under control that don't necessarily involve a needle. And Dr. Young will go into that in more detail. But I know that that's one of those things that if people who are already nervous about needles and then you are in the middle of a migraine, the last thing you want to do is try to face a fear while you're already hurting and fearful anyway. I'd say the biggest thing when it comes to avoiding the ER is to always have a plan. Know what your primary, most effective abortive is and have a backup. And maybe even have a backup to the backup. And you know what you're going to do at each step of the way. I had agreements with my doctors that if I ever had a migraine that lasted more than 72 hours, I would call them first, if it was not obviously the middle of the night. And so I would plan that, and I would call my doctor and say, okay, here's what I've done. I've run out of my options at home. What do you suggest? And sometimes his suggestion was, come see me in the office. We're going to do something. We're going to do a nerve block. We're going to do an infusion in the office and avoid the emergency room entirely. But I had to be willing to reach out and let the doctor know when things were not working. That was really important, that I had that relationship with my doctor to have that communication. And he was responsive to me. And it wasn't just, well, we'll see you in 3 weeks for your appointment. It was an immediate response to say, okay, we're going to get you in, or I'm going to write this prescription, call it in for you. We're going to do this thing instead of giving you to the emergency room, so that by the time he told me, yeah, you're really going to have to go to the ER, I really knew that I really didn't have another option. We'd already exhausted all of our options. So I have been able to stay out of the emergency room now since 2017, since the fall of 2017. I'm sorry, 2016. November of 2016 was the last time I was in the emergency room for a migraine. That ended up going in. I ended up going inpatient for that one. Prior to that, I had not been in the emergency room since I'd been prescribed home injections in 2013. So I was usually, prior to 2013, I was usually in the emergency room 4 or 5 times a year with an intractable migraine. So it really does work to have those plans, talk to your doctor, ask about the options, and then even develop plans for when your second and third options don't work, because it's rare, but it does happen.
Sharing your story with all of us, I think it's inspirational and educational to hear about someone who's made that good progress and the steps along the way. And I remember in the journey of Katie and I, at some point it was, all right, getting a letter from primary headache doctor that she could show someone in the urgent care, in the emergency room situation. And they don't have to follow it, but it's at least something different than just you asking for something. And then at some point she was in an integrated system and they put notes in her file. If she shows up in an urgent care situation, this is directly from someone within the system. And then of course, the ultimate goal, staying out of the ER entirely. So with that, we'll go ahead and transition over to Dr. Young, who will tell us about, from his perspective, what it is that patients can and should be doing here.
Thank you very much, Kevin. Using the abortives as effectively as possible is really an art form, but there is a lot of science behind it and a lot of sort of good thinking that can help somebody to make, a very decent plan that's very effective of keeping people out of the emergency room. Maybe not all the time, but honestly, I see some very challenging headache problems, and few of them go to the ER. And I'd like to show you, how I try to do that. Physician in me has to, tell you that I am conflicted. I have all kinds of research support, advisory boards, consultations, helps me to learn about new treatments. And I am the medical co-director of Control M Health. I tell my patients that there really are 4 boxes of treatment, and every visit is a visit where we talk about, how things are going with each block and what can we do to tweak it, and that it's always a work in progress. So we have, at least until, the progress is perfect and the control is wonderful. But there are preventives and abortives, and most of this talk will be on abortives, and then the mind, and then the body. So, maybe you should stretch, or maybe a meditation, or maybe a walk in the park can give you both mind and body. And what's your preventive, and then how is your abortive strategy working? And that's a visit. So the general principles of acute or abortive treatment is to recognize any triggers and, get out of the sunshine and get away from the stinky perfume and treat early. And this is the one that so many doctors and so many patients make mistakes about is, sometimes you just have to go around the stomach. If you're vomiting, it is a no-brainer that, the pills just aren't going to work. And it's a little bit dangerous too, in my opinion, because if you swallow a pill and then you throw up a little while later, did you absorb 10% of that? Should you take another pill? Did you absorb 90%? Are you going to overdose if you take the same thing? It gets, gets to be a guessing game, and it's really not good. So use non-pharmacological treatment, and I think Tammy gave a excellent discussion of that. And then use and don't overuse acute medications. And then that's what this talk really is about, is stratifying care. You can have a first-line treatment, a backup treatment, a rescue treatment. You can actually have a fork in the treatment plan. This is my menstrual migraine, and I know I'm not going to fool around with anything, or this one, is coming on slowly on a Saturday, and I've got all the time in the world to, get medicines in me as safely as possible and with minimum side effects. So just a simple way to break up the acute medications. There are non-specific medications that work for other things like non-steroidals or nausea medicines or steroids or opioids, which we don't really recommend, but they work for many other things. And then there are treatments that work just for migraine, ergotamine, DHE, there are 7 triptans, 2 Japans and 1 Ditan, and maybe some more of those to come. And as I mentioned, to have a backup plan, if you have a really great abortive and it works 95% of the time, you're really lucky that it works well 95% of the time. Well, 5% of the time, 1 in 20 attacks, that could be a few times a year that you're just out of luck. Get a backup plan. And if you need it, a rescue plan after that. So, be prepared. So this is how I think of it. There are 4 groups of medications that we can think about using first line or second line that are relatively safe. And here's the nice part is that while you don't want to use 2 things in one column, you don't want to use rizatriptan and sumatriptan, 2 hours later because the rizatriptan didn't work. There's no reason not to take the Advil or the diclofenac or the prochlorperazine or the ubrogepant with it simultaneously, one before the other. Column A can be matched with column B, and your doctor, when the single treatment doesn't work, can think about doubling up and choosing properties with you that make sense. So, I need something that really lasts a long time because my migraine comes back after 12 hours. But this non-steroidal works really quickly and gives me relief in just 20 minutes. And so we're going to combine a long-acting triptan and a quick-acting non-steroidal and get a good abortive, for that kind of attack or for the kind of attacks that I have. This is the art and science of choosing abortives with patients. Now, there's one more thing this is early to say, but I think it's really good news for the headache community, is that right now, the preponderance of the evidence suggests that the Japans, ubrogepant and rimegepant, do not cause rebound headache. And that, that there's something different about them. And that is astonishing news. And as far as we know, there's really no risk, from overusing. So, maybe the dopamine blockers like Reglan, metoclopramide doesn't cause rebound, but there are issues if you use too much of that. That's not, necessarily good for you. Right now, we don't have that for the Japan. So I think that that's good news. And then there are the problematical ones, the ones that really cause rebound and can cause addiction, the opioids and the barbiturates. I'm not going to talk too much about them. Occasionally I do prescribe them as rescue, but I know exactly how many pills my patient is using. I check, the website to know. I know if they're getting prescriptions from other people and they're getting into trouble. I have to worry for them about it. And, there are other issues like suppressing respirations and sudden death and things like that, I'm really really don't want to happen. And then there are things that make people that work for migraine, but there are reasons not to use them all the time. And some of those are sedation. So you can treat a migraine, but if, they end up sort of gaga and they treat every day, that's not very good. Or there are some medicines that have a very high risk of causing stomach bleeding if you use it every day. So I can use those once in a while, but I am concerned if somebody uses it too often because of the stomach. Those are examples. At the end of the day, you deserve the tools you need. You can be educated and responsible, and you deserve access to treatments that will keep you out of the ER. As Tammy pointed out, look for things that bypass the stomach. The one reason that is, if you're vomiting from a migraine and dehydrating and you can't keep in your preventives, and then your preventives abandon you because they're not in your body, because you're vomiting, and then the headache spirals even more out of control, and then you're screwed. So you got to get to the ER for that if you can't bring it under control. So that's really important. That's without even mentioning the horrible pain and all the other symptoms of such an attack. So talk to your doctor about getting more treatments prescribed at home. Many of the medicines, are available. You can learn to self-inject. We teach our patients all the time. The doctor is thinking as, the first lesson I got in medical school is that I have to have a dirty mind. I have to worry. I give somebody an aspirin and I worry that they're going to be, throwing up blood in a week. That's your doctor's job, but it's really safer to take a shot of something that works than to take tons of pills that aren't going to work and just, slam them in and end up with interactions that we can't even contemplate. Your treatment, I want a patient who's a partner, who's not a dish rag. Talk to your doctor and understand what their concerns are about prescribing various medicines for you, and find things that you're both comfortable with that will keep you out of the emergency room. You can do it most of the time.
Yep, that brings us right into the Q&A section here. So let's go ahead and say we had some good work earlier in this conference with role-playing conversations. And I know it can be challenging to think through how you would go about asking for these things. So I want to put Tammy on the spot a bit, imagining that Dr. Young is your doctor. He's not the amazing headache specialist he is. He's a primary care physician that doesn't specialize in migraine, but he has prescribed you your triptan before, and now you're wanting to ask for some more things to help you to better manage your migraine at home. If you could sort of give us a model of what that conversation could look like.
In fact, I had the conversation before, sure. So this is what I would do. Doctor, the Sumatriptan is working really well most of the time. I can take it once, twice if I have to, and it knocks out the migraine and I can get on with my day. But every now and then, about 3 or 4 times a year, it doesn't work. And I'm in bed for days and I'm sick and I'm vomiting, and the pills you gave me the Phenergan pills you gave me don't even work because I can't keep them down. And so by that time, I'm just out of luck. And the only thing I can do is go to the emergency room. And every time I do, they give me the same medications. They treat me with Toradol. They treat me with Phenergan. They might do an Ativan or something like that, but it's consistently that Toradol and Phenergan that always work every single time. And I've been doing this for years. I heard recently that these medications are available by prescription to use as injectables. Is that something we can talk about adding to my treatment plan?
Yes.
Yay!
Yeah.
Success!
Done. That was so sensible.
Yeah. That was great. And you heard it there. It was not defensive. It was not accusatory. It was well reasoned. It was creating an open-ended conversation to go back and forth with the physician, and with all that backup and reasonableness, I think that increases your odds of having a productive conversation. Dr. Young, we've had some questions come in. People sort of a lot of around what are the injectables that we're talking about here that can be used in an injection way as an acute or as an abortive?
Okay. So if you'll recall that the 4 columns. All right. So the Sumatriptan is one of them that's available as an injection. It has the most. In fact, there's a nasal spray that has that just came out with a substance in it to enhance absorption, and it's almost as quick acting, and it gets absorbed through the nose. The old nasal spray, a good portion of it, more than 50%, gets absorbed through the stomach, so it's a little bit less reliable. Those are 2 ways to get a triptan into you. DHE, it's not a triptan, but that's available as an injection, and many of our patients use that. And a nasal spray that is, the part with DHE, the part that gets swallowed and ends up in your stomach doesn't do very much at all. So, but the nasal spray can be helpful. So from column A, that's what there is. From the non-steroidal, it really is the Toradol injection, the ketorolac injection. So that's pretty much it. There's the nasal spray, the Spritz nasal spray. I guess that I should have counted that in, but it seems to my mind that's pretty weak. It's a kind of a small dose. As far as the by injectable, promethazine, the Phenergan injection is very painful, as is the Thorazine injection. So I don't prescribe those because the shots are said to be so painful. That can be done. Haloperidol, Haldol is not so painful. Now, I have prescribed Reglan and the Compro, the prochlorperazine or Compazine by injection too, and those can be patients can be taught to self-inject those. So those are the injectables. Our culture, we don't particularly cotton to the suppositories, but those are available and reasonable, especially for the promethazine and the Compazine can be given that way, the prochlorperazine.
There was a question about, can you take triptans and Gepants at the same time or close proximity? And I believe the whole point is the 4 columns, and you really can take one from one column and another from another column at the same or similar time.
Right. So far, there have not been any reported complications from mixing.
And I'll just address that there was a question on here, and this is a whole nother topic, and we'll put some of the resources in the folder for everyone. But it's a question of, okay, let's say despite all of these amazing strategies you gave us today, it didn't work, and I still needed to go to the ER. What are the strategies for how to have the best possible experience at the ER? And I know those sessions have been covered. Great articles have been written. I think Tammy yourself might have even written a great article on that. So we'll put some of those resources, because even when you follow all the strategies we talked about here, and let's say your physician is willing to prescribe a lot more of these things for at home, sometimes they just don't work and the ER is required. And so you want to make sure you're geared up for that. So I just want to thank Tammy and Dr. Young for sharing your patient story and your physician knowledge with us.
Our coalition is working together to solve the challenge of migraine and headache diseases and support patients wherever they are on their patient journey. None of this would have been possible without the generous support of our sponsors, who helped us bring Retreat Migraine to life digitally this year and support hope, community, and advocacy at such an important time.